We are chatting here today about social interventions as part of the treatment for psychological disorders. So, as we've talked in this course, we've talked a lot about the biopsychosocial model and how that impacts the development of well-being overall. And so we understand that, when a disorder is caused, it can potentially be prevented also in large part, by the people with whom we interact. Really, prevention and treatment are influenced in a large part by the social context in which the person is living, and any treatment and any good treatment formulation should really take that into consideration. So there are some different things that we can do to help to change the social situation. One of those things that we can do is group therapy. So sometimes we can actually use a social setting to help to treat a particular disorder. And so therapy in groups is something that has been done for decades, and it's something that is quite helpful. Um, Usually, clients receive treatment together with others. There's usually about 6 to 10 participants. And what it does is it creates a safe space where people can come together, share their problems or concerns, better understand their own situations, and learn from and with each other. And sometimes those relationships of just being in a place where other people know what you're going through is such a huge help for someone undergoing a psychological disorder. So, lots of advantages. It's usually cheaper than individual therapy. It also allows other people to help each other, which is kind of a cool thing. It provides social support, so that's just some good things. It allows group members to model successful behaviors to other group members. It's been found to be as or more effective than individual therapy. This depends again on the type of disorder you're having. Some disadvantages, though: groups are not for everyone. And there are always going to be issues surrounding privacy and confidentiality in a group. So, I mean, the goal and the hope is that you're going to be with people who are going to respect your privacy and your confidentiality, but you can't really guarantee that when you're in a group context. So, it's an important risk to be aware of upfront. Another way to change the social situation or to change the relationships that a person finds them in is to engage in something like couples therapy. And this is a treatment in which two people who are cohabitating, married, or dating meet together with a practitioner to discuss their concerns and issues about the relationship. Sometimes the goal of couples therapy is educational and can focus on things like how do we have better sex, how do we communicate better, or how do I better, live with this person who has this disorder. Other times, the couples therapy is to actually resolve things, and the goal of it is like a direct couples intervention, which can be a very, very important thing. Family therapy as well can be something that can be helpful to change the social context in which someone finds themselves. Um, Oftentimes, the meeting is precipitated by a particular problem with one family member, and so everybody comes together because they're here to talk about so and so's problem with X. And family therapy is really based on the assumption that the problem is the result of an interaction among the people in the family. So the problem person is not usually the problem person, but it's the confluence of relationships within the family unit that cause problem. Now, um, couples therapy and family therapy, they're really type of what we call systemic therapies. Um, Now, systemic therapies are usually associated with kind of marriage and family therapy approaches. It can be used kind of as its own standalone approach, but really, when you're involving couples and you're involving families, you're beginning to look at the role of systems and relationships and the interactions that these systems and relationships have with each other. Now, the belief is that if one part of the system changes, the overall system changes, and that change can be positive or negative. There are many, many different variations of systemic therapies, and really, I mean, you could take a course just on systemic therapies. But if you follow that link, you can kind of have a basic snapshot of what systemic therapies really look like. Now, another way to change the social situation of someone is to consider helping them to join a self-help group. And so self-help groups are voluntary associations of people who share a common desire to overcome some psychological disorder or to improve their overall well-being. And these groups have been used with great success, particularly for addictive behaviors. But there are support groups or other, other self-help groups for things like, depression or anxiety or OCD. So there are some important groups out there. And usually what happens is you participate through regular group meetings. These group meetings are held with the supervision of kind of a trained leader. Um, Oftentimes, self-help groups tend to integrate religion and spirituality as well. And one of the really big key things is they really discourage self-blame. The goal is to get better, right? There are also other services that can be helpful when we're looking at the social context of a person. So these would include community mental health services. And these are psychological treatments and interventions that are distributed at the community level. And so the goal for these programs is to establish programs that will help people get the mental health services that they need. The emphasis, though, which is different than like going for therapy, the emphasis for these community mental health services is on prevention. And so these are services that are provided by nurses, psychologists, social workers, etc., in such as schools, hospitals, police stations, drug treatment clinics, residential homes. And community prevention, when we're talking about this, it really is focused on one of three levels. So it focuses on either primary prevention, which means that every member of the community receives the treatment, secondary prevention, which focuses on people who have identified risk factors. So these are social, environmental, and economic vulnerabilities that make it more likely that a given individual will develop a disorder or have a specific problem. Or it focuses on tertiary prevention, and that's treatment that focuses on people who've already been diagnosed with the disorder, but to help them along. Now, there are many, many different types of community prevention programs, and really a lot of them are focused on the early years, and with good reason. If we can get kids by the time that they are 5 and we can help to set them up for success, that can be a very, very helpful thing. Now, there are many different programs that are out there that are excellent. Programs like Head Start, programs like Kids First, the early childhood intervention programs that are across our province. So the link here is for the one for the Battlefords specifically, but there are multiple ESIPs across the province. And the goal of these programs is to make it easier for individuals to continue to live a normal life in the face of their problems and or in the face of risk factors. And the types of interventions that are done by these programs include parent support, so that's like parent training and mentoring, stress management, emotional regulation, practical support, so help with housing, job skills and training, literacy training, academic upgrading, connecting people to therapies, and in some cases, removing a child from a stressful or dangerous home situation. Now, I'm going to hop from there into how do we actually know what works in prevention and treatment? So we've talked a lot about all these things. So the one question you should probably have at this point is, well, you've said these things are good, but do they work? So the way that we know if things work is through the use of outcome research. And outcome research are studies that assess the effectiveness of a medical, biological, or psychological treatment. And the independent variable for these outcome studies is the type of treatment, and then the dependent variable will be based on some kind of outcome measure. And usually, client characteristics are some of the control variables that are also kind of controlled for, I guess. And there we go, yeah. So here we go. So the outcome measure of treatment benefit. We've got to have a control group. So usually in outcome research, we've got a control group that does not receive a therapy, and a treatment group that does receive the therapy. And what we look at is what's the differences between these groups. Now you might say to yourself, well, that's kind of a silly way to set things up because obviously the control group is not going to improve. But you would be wrong. Sometimes people improve just by virtue of different factors, of time passing, of the belief that that something might kind of get better, or for various things. So we know that kind of that control group is a necessary piece. Placebo effects too have a huge impact on outcomes. Now, there's some important threats to the validity of outcome research, right? So natural improvement. So that's what I just mentioned to you, which is the possibility that some people just might get better over time. even without treatment. So to demonstrate that the treatment is effective, the people who participate in it must be compared with another group of people who do not get the treatment. The other thing that is important to note is that clients often experience what we call non-specific treatment effects. And these are things that occur when the patient gets better over time simply by coming to therapy, even though it doesn't matter what actually happens in the therapy sessions. So the belief that I'm doing something that's going to help me get better leads to me actually getting better. And the other thing too is, again, this idea of placebo, right? So I get better because I believe that you're giving me a treatment, therefore I'm improving. So in order to assess psychological therapy, then we've got people in a control group and then in the active intervention group. Um, so some outcome studies compare a group that gets treatment with another control group. So this is helpful because it controls for the possibility of natural improvement, but it doesn't control for non-specific treatment or placebo effects. So an alternative then is that you've got three groups. You've got your actual treatment group, a group that gets a placebo treatment, and then a group that gets no treatment. And so in a setting like that, you can kind of look at all three of those levels. All right. Now, after we've done all of these studies and you get a successful study and people say, oh, that's great, this treatment seems to work, and then somebody else comes, they replicate it, and they also do that, and then they say, oh, yeah, it seems to work, this is great. Well, what happens then after several studies have been conducted that demonstrate positive outcomes or negative outcomes, that demonstrate the outcomes of a particular therapy, the results are often combined then into something that's called a meta-analysis. And a meta-analysis is a statistical technique that uses the results of existing studies to integrate and to draw conclusions about those studies. So because you're drawing then from multiple studies and multiple participants, you can have a very, after a meta-analysis is conducted, you can have a fairly strong, I guess, belief whether the thing works or not, simply based on what the research actually shows. So one of the more impactful meta-analyses that have happened was one by Smith, Glass, and Miller in 1980. And they summarized studies that compared the different types of therapy or that compared the effectiveness of therapy against the control group. And so they combined the results from over 475 studies with a sample size of over 10,000 participants. So it was pretty impressive. So they coded these studies, and then they measured the effectiveness of treatment through something called an effect size. Okay, so they create an effect size for each individual study, and then using this statistical technique, you can then create an overall effect size for treatment. And so here's what they found was that the average effect size for the influence of therapy was about 0.85, which indicated that psychotherapy had a relatively large positive effect on recovery. All right, so these are the normal curves of those that did and did not receive treatment. And so other meta-analyses show substantial support for the effectiveness of specific therapies, including CBT, couples and family therapy, and psychoanalysis. So it's actually led to the creation of a list of empirically supported treatments. So for example, cognitive therapy and behavior therapy for depression, that is a gold standard treatment. Cognitive therapy, exposure therapy, and stress inoculation training for anxiety, that's another gold set. CBT works well for bulimia. Behavior modification works excellent for bedwetting, and so forth. So here's the question then. Is one therapy more effective than others? Well, here's the thing. Research has actually not found that one therapy is more effective than all others. However, research continues to show that what is important is the quality of the therapeutic relationship between the client and the therapist. So the best relationships are the one where a therapist listens empathically, provides unconditional positive regards towards a client, and is congruent in and of themselves. Boy, doesn't that sound a lot like Rogers' person-centered therapy? Absolutely it does. And it really reiterates the fact that what Rogers captured there was the value again of the therapeutic relationship. That is the thing that that has the best bang for your buck in terms of outcomes in therapy. Now, meta-analyses also support the effectiveness of drug therapies. So, for example, psychostimulants have been found to reduce the symptoms of ADHD, and positive and negative symptoms of schizophrenia are reduced by antipsychotic medications. We also know that people who take antidepressants for mood disorders or anti-anxiety medications, they almost always report feeling better. However, drugs are less helpful for phobic disorder and for OCD. Although drug therapies provide temporary relief, it's again important to remember that they don't treat the underlying cause of the disorder. Many drugs also have negative side effects and the potential for addiction and abuse, and so because of this, doctors often prescribe the lowest doses possible for the shortest possible periods of time. Again, medications and decisions regarding it should be carefully weighed and based on each person's needs and circumstances. Well, what about social community approaches? Do they work? Well, the challenge is it's very difficult to measure their success because they occur in community settings, they impact a variety of people, and it's really difficult to find and assess valid outcome measures to determine whether or not this thing is working. Um, you know, Programs have been designed for all kinds of things, and most of them are successful, but the changes are often modest. Again, you're not able to control all of the factors that would make it difficult for you to improve. Um, at the same time, you're also dealing with people with varying levels of motivation. I mean, some people who sign up for a specific trial or a specific community-based therapy are there because they really want to be there and they really want to get the most out of it. For other people, they're kind of forced into it, or they think it's a good idea, or maybe so anyways, it's hard to assess the true value of these programs for a variety of reasons. First of all, it's hard just to measure it, and secondly, you're also dealing with many different motivations for what this program means. So, one of the big recommendations is that it's really important for the community to work with researchers to determine which aspects of which programs are the most effective and to keep doing that. Now, I'm going to wrap up here on kind of my final thoughts on this course for you. So I hope that by this time that you have kind of felt a strong case for the value of psychology. Now, I want to give one last piece of evidence for why I think psychology is so well positioned to be a useful discipline in this day and time. And so this is based off of your reading from the Murdoch and colleagues article. The work done by psychologists overlaps considerably with other disciplines. I mean, we work so closely with nurses, with social workers, with addictions counselors, with mental health therapists, with couples and family therapists. So why should you choose a psychologist over another discipline? If you have a choice, you need to get some help. Why do I think you should choose a psychologist over another discipline? Well, I think there's a few things that we kind of have going for us. So one of them is that we rely on the scientific method to hypothesize, to test, to collect data, to revise, intervene, and to revise and intervene until the problem is solved. The other thing too is that all psychologists are broadly trained in psychology and its connections to other scientists or sciences, before being trained as professionals. So being able to draw off of this wide base of knowledge of the biological and the cognitive and the developmental and the cultural and the social factors that lead to different behavior allows and positions us to better understand human behavior than other disciplines. It's also my belief that we do have a unique skill set and unique knowledge that equips us to integrate information and to make mental health diagnoses. We are trained in case formulation and in developing helpful case formulations, in understanding and being able to assess for a disorder and then being able to intervene for that disorder. So, the study in brief from Murdoch and colleagues. So I really do want to encourage you to read it because it will be on the exam, on your final exam. But in the study, broadly, what the authors did is they reviewed the course calendars for graduate programs in counseling or clinical psychology, undergraduate programs in medicine, nursing, and social work, And what they did was they wanted to review the number of psychology or mental health credits required to enter these programs and graduate from the program, in addition to the number of practicum and internship hours that are required in that program. And so here are the results that they found. Most nursing, social work, and MD programs don't require any psychology courses in order to enter into a professional program. Most nursing, social work, and MD programs require minimal hours in a mental health setting in order to graduate from their programs. And all psychology students have significantly more education and experience regarding mental health concerns upon leaving their programs compared to these other disciplines. Here is the chart for you that you can kind of see. And even in a counseling master's program, your number of entry credits needed to be able to do the program are significantly higher than all of the other programs. The number of practice hours that you have, heck, like we spend a lot of time in rotation. Um, you know, Total hours of practice as well is significantly higher than in some other disciplines. So why psychology? I feel like we really are positioned well to be your mental health people. In the article itself, it says, given these results, it is hard to understand how job descriptions could suggest that nurses, social workers, and psychologists can equally fill the role of a mental health therapist or behavioral health consultant when it is quite possible to obtain an undergraduate nursing or social work degree in Canada with no training in psychology or any related aspect of mental health. So why do I think psychology? Because we are your people. We are trained in this. This is what we do. This is our bread and butter of our training and our work now. And so I want to encourage you to think of us. I think we provide a unique perspective on well-being. We use research and we have a desire to rely on empiricism in order to display the evidence. Psychologists are also bound by a comprehensive and enforced ethical code, which governs our interactions with clients, colleagues, and the public. Finally, psychology also helps us to function super well on interdisciplinary teams and to be a meaningful contributing team member. The ultimate goal of psychology is to support mental health, well-being, and optimal functioning, and that's what we want to do for you. And while the training is long and it is hard, it is definitely worth it in the end. And so if this is a career that you're considering, I would encourage you to shoot for the stars and to go for it because it is a worthwhile profession. Now, do you have any questions about being a psychologist, about something psychological, or any unanswered question remaining from this course? If so, get in touch with me. For me, it's important that you leave this course having your questions answered, and I love answering questions about my discipline. And so if there are things I can help for you, please do get in touch. All right, I'm going to stop here, and we'll touch base soon.